Hello, good afternoon to everybody. I'm Bruno Millet from Paris, University of Sorbonne. And I'm very pleased to be there for this session on neuromodulation techniques. I remembered that 2 years ago we organized this first session on neuromodulation. There was not a lot of many people in the room. I can see that it increases a little bit, so it's good. Just I want to tell you that neuromodulation is, for me, is what can I say, a third revolution in psychiatry. And things are going to change a lot with the arrival of those techniques with repetitive transcrânienne magnetic stimulation, deep RTMS, high-frequency deep brain stimulation, TDCS, and soon ultrasound. And so it's sure that those techniques of neuromodulation are going to be put forward in the frame of psychiatry and within the frame of addiction. So today we have what can I say, a prestigious session with three speakers, three international speakers of very notorious and specialists in the field of brain stimulation and RTMS. Just before, I just want to honor the existence of Nolan Williams. I don't know if you know who was Nolan Williams. Nolan Williams was a specialist, an American specialist of repetitive transcranial magnetic stimulation. He created in Stanford University the SMTr procedure in RTMS, SMT for Stanford Accelerated Individualized Neurotherapy. Nolan passed away last week. It's very sad news because he mentored some students of us, and so we are very sad, and we would like to share this loss with you. So we are going to start this session with the first speaker, Eduardo GARZA-VILLAREAL, who is associate professor at the University of Mexico. He's going to speak about the use of RTMS as a treatment against psychostimulants dependency. And so we are very pleased to welcome you in France and particularly in Biarritz. Please, Eduardo, it's your turn.
Thank you for the introduction. Me pidieron que diera esto en español. Espero que no haya problema. Espero que tengan la traducción. Bueno, voy a hablar sobre la investigación que realizo y además sobre algunos casos clínicos que tenemos en el laboratorio sobre psicoestimulantes. También he hecho estudios con alcohol. Ahorita estamos trabajando con alcohol también, pero solo voy a hablar de la parte de los psicoestimulantes. Como contexto, trabajo en el Instituto de Neurobiología de la UNAM, campus Querétaro, en donde tengo mi laboratorio que se llama Neuropsiquiatría y Neurotoxicología Translacional. Y además tenemos la unidad de resonancia magnética, donde hacemos nuestros estudios, donde tenemos dos tipos de resonadores, de 3 teslas y un resonador de 7 teslas para pequeñas especies como ratones y ratas. Yes? Okay, they asked me to switch to English now, so I'll go back. But basically, I work there. And I lead my lab, and I also lead the neuromodulation unit at UNAM. which we basically, it's an outpatient clinic that we have, and it's treated as a private service at the moment. However, we expect to be introduced into the government services. And so we have both experiences. We have the research experience and also the clinic experience. And well, the lab goal is to try to improve the treatment of patients with substance use disorders in general. And we do this with different lines of research, and I'm going to talk about the main line of research now, which is neuromodulation. And I'm just going to put my time here, because otherwise I don't know how long I go. Okay. So I like to work in translational research because it's difficult. It's really difficult to pass from the first stages, which is the animal research, into the human research, and also going all the way back, trying to adapt research in humans into animal research. So this is what I'm trying to do, and it's very hard, as you know. People working there know how difficult it is. However, it's very important, I think, to do it. And so I'm trying to use MRI as a cross-species biomarker because I think it's good because it's non-invasive. You can use it in longitudinal settings to study changes. We have similar sequences in any animal and similar variables that you can extract from them. So I think it's a really good tool to do translational research. And as context, in Mexico, right now have a huge problem with especially methamphetamine and amphetamine use disorder, more than the other ones. And there are many reasons for that. However, this is a graph showing treatment seekers. So we have probably a lot of people that are not treatment seekers, and the new numbers on how many people are actually using drugs come out, I think, next year. So we'll know because the last one was many years ago. And so it's a huge issue now, and this is why I study now psychostimulants. And in the different regions here in Mexico, depending on the region, you have different uses of drugs. So opioids are not very common below the border. That said, we know now that most of the drugs in Mexico are laced with fentanyl. So we will have a problem in a few years, probably. So just I'm going to go a little bit basic, and then I'm going to go to the actual research. And so basing ourselves in the theory of from Volkov and George Koob on how addiction is arising. We have some different cycles, different periods in the brain that in the addiction cycle that relate to different regions of the brain depending on the stage, like binge, intoxication, withdrawal, and preoccupation, etc. And we now have interoception there in that map, and it's interesting because now we're seeing, and I'm seeing in my research a lot, that the thalamus network is very much involved, and also I think we're missing the cerebellum there. So there's a lot of for neurobiologists, for example, that we're missing some of the key regions there, but I think adding the interoception regions has become really important. So this meta-analysis that we did in 2021, we show that in general, with different types of drugs, in terms of addiction, we have different changes in the brain. This is volume changes. Volume changes in the regions that we just saw in the last diagram, and also in white matter to the right. So white matter is to the left, to the right we have white matter. And below we have, specifically for psychostimulants, we see some changes, especially in prefrontal regions, motor regions, etc. So a lot of the psychostimulant seems to be affecting more the prefrontal regions. That's what we think. And in this study that we did with animals, with self-administration in rats, we also find very similar changes in local volume, very broad changes. These are changes before and after acquiring self-administration of methamphetamine. And we see, in blue, we see reductions in volume, and in red, we see increases in volume, which we actually don't know what it means. We think reduction in volume means losing neurons, but then what does it mean when you increase volume? We really don't know. It could be different things. So we're studying that with using histology, for example, and this is insula cortex. And we're seeing with methamphetamine some actual changes relating to increases in size because of increased glial cells and neurotoxicity, apparently. And in terms of function, this is the latest, some of the latest meta-analysis show that there are different regions related to the changes in resting state fMRI or task fMRI. And we, again, see a reduction in function in regions related to the default network and also cerebellum, so besides the other ones. And we know the importance of, we're here, and we all know that, addiction has a huge, huge relapse. 40 to 60%, much more, I think, in my setting, like 80% or so. So I think it's very important to, of course, introduce new techniques, such as TMS. So briefly, we call it non-invasive brain stimulation now. So there are many, many techniques now, as it was mentioned. And so FDA approval for the first one and for major depression was in 2008, and neuroethics and Neurostar system. And then BrainsWay, of course, was accepted in 2020 for smoking cessation, which was the first actual device to do it. I won't talk about it because we have the man here who's going to talk about it, Dr. ZANGEN. And then the CE approval was for adventure was in 2021 on substance use disorders. And I'm going to talk a little about the papers that created this approval. And so we have usually deep TMS, which is the BrainsWay, and conventional TMS, which is the one most people use at the moment. However, it's getting more prevalent to use deep TMS as well. And so basically, you have an electromagnetic coil that creates a magnetic field, and then that creates a current inside the brain. It usually doesn't go too deep in the brain, except, of course, if you're using the deep TMS. And now the ultrasound stimulation is getting it's actually getting more popular because it can get to deeper regions. And usually the flavor of TMS you get, you can call it repeated TMS or not, because we also have theta burst stimulation. Depends on how many pulses you get in which time. So it's like the flavor of the TMS you're getting. So you get standard TMS with usually 1 to 10 hertz, and that's usually 1 hertz is considered inhibition, and more than 5 hertz is considered excitation of the neurons. And with deep TMS, you get the same. And with theta burst, it depends on what you're using. Theta burst is actually a burst of 5 hertz stimulation with high frequency, so you get 50 hertz at the end. And you have the intermittent theta burst, which is supposed to be excitatory, and continuous theta burst, which is inhibitory. That's the basics of it. And how does it work? We think, or what we think now is that, okay, TMS excites a region in the brain, the neurons there, and then you excite the whole circuit from there. So this is the main idea from this, and we have this knowledge since 2017 from this paper from Diana, this review, which shows that after excitation or inhibition, you get the whole circuit involved. And this also comes from studies from other people like Michael Fox, which has studied, for example, the relationship between DBS stimulation targets and TMS stimulation targets in the cortex. And we see that you get the same circuits related to them. So if you're stimulating with DBS, you're basically stimulating the same, or it seems to be the same as if you were stimulating the cortex, because all the circuit is connected. So in a way, what we think now is that when you're stimulating cortex, you're actually stimulating the whole circuit, and that's how you get the effect. And we can see this, for example, in studies by, again, Michael Fox and Robin Cash from Melbourne, that the more you get to the subcortical target, the better you get to hit the subcortical target, the better improvement in depression. In this case, for example, the more relationship between the subgenial cortex in depression and the dorsolateral prefrontal cortex target, then you get a better improvement in clinical change. And this recent review that I work with Hamed Ekhtiari this year, we still have it in preprint, shows that the most common stimulation site, which is in blue for TMS, you can ignore the other ones for now, is actually the dorsolateral prefrontal cortex, but there are many, many different targets now. And especially now with BrainsWay, for example, you get the ACC and the insular cortex, and we'll see in a bit of it why. But some other ones are trying to simulate the cerebellum as well. And the way TMS is studied now is in different settings. We see that a lot of research is done in males, not a lot in females, as it is common. And then we have treatment seekers, non-treatment seekers for detoxification and recovery, and different types of drugs. And of course, we're going to talk about cocaine and methamphetamine, but then that's how kind of the research that you get at the moment. And we think that the effect of the TMS is because it's inducing a reduction in craving or an increase in abstinence. And this is because in animal studies, we see that if you stimulate the middle prefrontal cortex or the prelimbic cortex, then you get a reduction not in craving itself, but in the seeking of drugs. And supposedly in humans, we can see the same, or maybe we see the same. We really don't know if it's the same. However, for example, there's a diversion onto what is the prelimbic cortex in rats compared to humans. Is it the dorsolateral prefrontal cortex? Is it the ventromedial prefrontal cortex? We don't know. However, we think it is related to that. And we know because of studies by Colleen Hanlon since 2013, where she simulated inside a scanner, and first to see the pathway that is activated with the TMS. And we see that simulation of the dorsolateral prefrontal cortex, which is on the top, and ventromedial prefrontal cortex, which is below, induces changes inside in subcortical regions as well, in the same regions that were targeted for stimulation for addiction. So there you go. And then she did some studies with cocaine, and she found that cocaine users had changes in the circuit. So when she stimulated, she didn't get the same response with both signal in both regions. So we know that that circuit is affected, and we knew that, but now we have a confirmation that with TMS you also see it. So just one stimulation doesn't create the same effect as in controls, non-users. And so cocaine users, for example, she also found that if you stimulate the ventromedial prefrontal cortex, then you get this, when you stimulate them for 6 sessions, for example, you get this reduction in functional, in fMRI, both signal in these subcortical regions and other regions related to addiction. And so I like to see this paper as one of the main papers relating to what the effect of TMS in addiction is doing. And she basically describes that you have these two circuits working together, or not together maybe, in addiction, which is the limbic circuit and, of course, the mesolimbic circuit, and then you have the frontostriatal circuit, where you have different regions that are competing against each other. So one is when you get craving and then the patient wants to use a drug, then you get this limbic circuit pathology, and the executive control tries to stop you from using the drug. And with TMS, we think that with either, if you stimulate the dorsolateral prefrontal cortex, you're actually stimulating the executive control network, and you're actually making the patient try to stop better. And if you stimulate the ventromedial prefrontal cortex, you're actually trying to stop the patient from feeling craving. And this is the theory behind it. Still need to be studied more. And in 2023, there was this meta-analysis of different results with TMS in different drugs. And if we focus on cocaine and methamphetamine, we see that with cocaine, 50% of the studies show a positive outcome, and with methamphetamine is 88% actually. However, there's very little studies, as you can see. They're very controlled, and with placebo, for example. So we need more placebo-controlled studies with a good effect, I would say, in both of them, but we also get out the drugs. Like alcohol doesn't have a huge effect, or seems to be not as good. And so, and then again, in this review that we did for this year, we found that TMS had significantly medium effects in both craving and consumption, relapse reduction. And the most effective approaches that I'm going to show now is that high-frequency deep TMS with the H4 coil from Rainsway, targeting ACC and bilateral insula, seems to be working very well. And high-frequency TMS of the over left dorsolateral prefrontal cortex seems to be working very well as well. And increasing the number of sessions was linked with larger reductions in craving and consumption. And we also found a positive effect correlation between the number of pulses, which is the dosage for us mostly, and craving reduction effect size. So yeah, so it seems to be that more pulses is better. And in dorsolateral prefrontal cortex seems to be better. However, there has to be more studies with the ventromedial prefrontal cortex. And in terms of psychostimulants, I'm going to talk about a little bit more about this. And so there are two main publications that you may know of that got the acceptance for the MAC-VentureC approval, which are these two from Terraneo and Matteo, both from Italy. And the left one, they saw that TMS on the left dorsolateral prefrontal cortex reduce the use of cocaine in patients and relapse rates. And on the right one, it was a continuation of this with a protocol. And briefly, the protocol is 5 days of stimulation, daily stimulation, and then the rest is once a week. And they found that RTMS was better than treatment as usual for a long time. The patients would monitor, so it goes for a long time, as long as you want, really. But this is what they found. So this is how they got accepted for C acceptance in Europe. And in 2021, we published this study. As I said, now I'm working more on alcohol, but we're going back to methamphetamine. But I can show you this paper that this work that we did. It's a double-blind randomized control trial where we did TMS 5 hertz, and then we also, as an add-on treatment from treatment as usual, and we also did some MRI. And it got more publicity because we got the data open. So if you want to download the data, you can just take a picture and download it. It's all the imaging data and all the clinical data open. And this has helped, move a bit more people interested in this and analyzing our data. So what we did was we had two groups, a sham and an active. We used a MAC-Venture coil stimulator, and we had a double blind for 2 weeks. And then afterwards, we did active TMS for at least 6 months. Some of them we finished for a year, but mostly we analyzed 6 months. And we did MRI in each stage. And double blind was 2 weeks, and then open label for 6 months. And some of this is the coil we use, and some of the targets that we actually did on our patients. And what we found at that time was that we significantly reduced craving in cocaine use disorder patients, and we also reduced impulsivity significantly. And I was very interested in depression and anxiety because, well, comorbidities are very, very important for me because of quality of life, more than, okay, are they consuming, are they doing more drugs or not? I'm really worried about quality of life. And we actually found that it was the same for both groups. So we had an effect of just using the simulation as a sham, which is interesting because it's interesting in many ways. But I was certain that, because we're using TMS for depression as well, you get more effect. But in our study, we didn't find that. And also sleep disorders. This was, at the time, I had a meeting with Nora Volkov, and she asked me to do this sleep study because she was interested in sleep as one of the markers, and we didn't find it at the time. We also found changes in DLPFC connectivity with the ventromedial prefrontal cortex, very small changes, however significant, that related to the reduction of craving and impulsivity. But we also found that a stronger effect was between the VMPFC and the angular gyrus, right angular gyrus, which is part of the FOMO network. So we found 2 networks related to the craving effect. And so after 6 months, what we found was a reduction in craving, but that went back after 6 months, which was interesting. And in all of them, it went back after 6 months, except sleep, which was very stable. And I think it was depression, yeah, also it was very stable. But 6 months after the stimulation, we were stimulating once a week, and we still got this craving going back up. We saw reduction in consumption frequency and grams per month in most patients. And again, in the connectivity, we also found this effect of changes. So at the beginning, it was going up, and then reduction after 6 months, which followed, craving. And later, we did this study with colleagues from Iran, and we found that the craving improvement using more advanced fMRI analysis, we found that it was related to actually cerebellum, which was interesting because I'm very interested in cerebellum, but it was interesting to find this region related to the craving improvements. And we also found some, we did the diffusion in this data, and we also found that increasing density of axons and dendrites and axon organization in the circuit that we're stimulating, which is the DLPFC, VMPFC, and also subcortical circuits were more related to the prediction. So before stimulating, we found that the white matter in these regions predicted if they were going to have craving reductions. So yeah, I think I went a little bit fast, but I need to talk about the clinical cases that we have. So what's next for the field, or what we are doing now? So one thing that Hamed Ektiari has talked about many times, every time I talk to him, is about having better markers, biomarkers, neuroimaging biomarkers. One of them, I'm interested in the third one, which is the prefrontal striatal connectivity, or any type of connectivity related to fMRI as a marker of improvement. And we're also interested in new targets, better targets, because dorsolateral prefrontal cortex was used because it was used in depression mainly, but not, and of course it has a relationship with the limbic system, but we are finding now there might be better targets, and we see this with the BrainsWave, for example, the study stimulating insular cortex. And basing ourselves on this paper by Michael Fox's team, where they found that brain lesions actually showed patients with brain lesions due to stroke got better on addiction, on their tobacco addiction and alcohol addiction, just after the stroke. And they found that it had to, because it related to this circuits, which basically you see the insula, ACC, ventromedial prefrontal cortex, and so forth. So you see there are some other regions that we are actually interested now. And so in animal studies, I told you I do animal studies as well. So we're trying to do DBS in these animals, but to find a good target, we did this ablation of the insula and ablation of the ACC, just to see what happens with craving. And we actually found, and this is not published yet, we found that both targets, when they're ablated, then you get a reduction in craving in rats that were addicted to, in this case, to morphine. So we're still studying this, but the idea is to do this with DBS in the lab to find better targets. And another next step now is personalized TMS, which maybe you have heard about. Robin Cash has proposed this using functional connectivity map, resting state connectivity maps to try to find better target in the dorsolateral prefrontal cortex related to subgenual cortex in depression. And Chao Ganyan from Beijing, he has also another paper that I was involved in, using actually big data to try to find this better target for individual stimulation. So now we're working together in trying to find a better target for stimulation in addiction, using our data and other data, of course, and because we are now showing that, okay, it's more related to the ventromedial prefrontal cortex, so maybe we should focus on that connectivity between the cortex and the ventromedial, so the dorsolateral prefrontal and the ventromedial. And finally, I have two cases because we also do clinic now. We have some experience in the clinic doing this, and we started with the European approved protocol. And so the first case is a male, 32 years old, with diabetes type 2. His main drug of use was alcohol. However, he also used cannabis, cocaine, and some inhalants at some point for 17 years of consuming all of them, but mainly alcohol. And this is his pharmacological. When he came to us, he had this medication. And we used, first he entered a protocol that we had, a protocol that we have for research for 20 sessions for 4 weeks, and we found that he had two months of abstinence after the treatment, but then he relapsed, and he came to us again telling us that he wanted to do this outpatient clinic. So we started the protocol with 15 hertz of RTMS for 16 sessions, so 5 sessions in 1 week, and then 11 sessions in 11 weeks. And he stayed in abstinence for 3 months, but then he relapsed at a party. And then he returned to treatment by himself, which is good because he was never wanting treatment. So we think that's a good thing. But you can see the visual analog scale on craving to the right. It was kind of in the middle when we started, and then it was flat for a long time. But then he got relapse again. So we're going to stimulate him again. And we work with the psychiatrist, but we don't have a psychiatrist inside. So we So we have patients that come from the ARC clinic. And then the second case is a male, 38 years old, 10 years consuming mostly methamphetamine. He doesn't show other drugs of use, and no drugs when he came to us, no other medication, so only CBT, exercise, and changing lifestyles. He came from residency program that we called, where they stay in a clinic for a long time. We did the same stimulation, and he got a good 5 weeks of abstinence. However, he got some, you can see he had a craving peak there. And after that peak, he relapsed again. And before it relapsed, his psychiatrist prescribed atomoxetine at session 8, which we don't know why. And in the end, he got relapsed, and now he's going back to the residency program. So this is our clinical experience for now. And so the takeaway messages, I think, are that TMS is showing positive results in all sorts, or at least in stimulant disorders, reduces craving, impulsivity, and stimulant use, could be part of an integrated therapy. I don't believe in just a single therapy, and I think it would be good if we can combine it with something else. But we don't know about the comorbidities. I don't think there's a lot of studies showing that, and I think we're trying to show that, what's happening with the depression, anxiety, psychosis. And individual targeting, it may improve outcomes. We know that from depression, but we don't know in addiction. And animal studies, I think, are a good way to try to understand this more easily. And I want to thank everyone that works at my lab and my students here. We're almost ready for Dia de Muertos and Halloween, so thanks everyone for listening.
Thank you very much, Eduardo, for this important speech about your works. Any question? Maybe we have time for 1 or 2 questions. Yes. Yes.
Formerly, cocaine or stimulant use were contraindication for TMS. Colin Hanlon proved it's safe. For the 8 studies you speak about, how many were with theta burst and how many were with high frequency?
Yeah, so in my research, we haven't used theta burst because it's more painful for the patient. And I think I prefer a more conservative approach, which is the RTMS, so trying to stimulate for a long time. I don't think it will make a huge difference because it is just more pulses, but in a very short time. It might be a bit worse in terms of the risk. However, this is something that we really don't know, and we think TMS is very safe in general.
Yes.
So I will probably do it if I have to, yeah.
Yes. Why did you choose 5 Hz?
Oh, yeah, well, I was working at the National Institute of Psychiatry, and they were actually more conservative than I was. and they also were afraid of the risk and the pain for the patient, because TMS can be painful.
Yes.
But then now for the clinic and for the research, we'll use at least 10 Hertz. I think more in terms of frequency, it's better. 10 to 15 Hertz, I think it's better.
Yes.
But in my experience, at least.
Thank you.
Thank you.
Another question? In your experience, the main target was the dorsolateral prefrontal cortex. Does it mean that this is you have the best results with this target, as it is the case for alcohol? Does it mean, in your opinion, that the target should be the same for cocaine addiction and alcohol addiction?
It's a good question. We don't really know, and this is a good question. Should we individualize target as well? And I think this is a discussion now that should be done, because at least in our experience, dorsolateral prefrontal is working fine. for cocaine, for example, but as you say, alcohol, we see less, better results. And it might be because, maybe you need to inhibit the ventromedial prefrontal, we don't know. But we're trying to find in animals what works in animals, if it works better. Like I'm right now looking into the ACC as a better target, maybe. And you can test that now with either coil. And so ACC, insula seem to be also very related to the craving. And so we don't really know, but from the data, it seems to be the case that it might depend on the drug as well. All drugs, of course, affect the same circuit, but it could affect them in different ways that we think. So maybe it will be interesting to study that.
And if I understood well, the greater the response was with the greater the subcortical structures were hyperactive or hypoactive. No, there was you find some correlation between the efficacy of the technique and the reactivity of subcortical structures. Did I understand well your data?
Yeah, I think so. This is the thing. We're trying to simulate the whole circuit, which involves the subcortical regions. So I think you need specifically you need enough power to simulate the whole circuit. I think that's the idea, and I think that's the reason that you get better results depending on where you stimulate. If you stimulate in a place where you get a response from the subcortical regions, then it means at least that you have more circuit involved.
Do you think for this indication, with prefrontal dorsolateral cortex, we have much more to take into account comorbidities, I think ADHD?
Yeah, we haven't had any patients with that, and I think it's interesting because then we will see. When you get to the clinic, then you get patients with everything, not the same patient that you get in the study. Okay. So I think it's getting more complicated. With ADHD, I have no experience with TMS, but I think, again, we're looking at trying to get some cortical targets. So I think that will be the way to go in the future, is to try to find maybe if you're stimulating the whole circuit, maybe you're getting patients better.
And last one,
yes,
may you share a secret with us, if you know it? Will the next brain stimulation congress be held in Mexico? Or you don't know it?
I don't know, and you haven't told me. I don't think so, but
maybe.
We do a addiction we call it a symposium, addiction symposium, every 2 years. So I will probably send it to you in 2 more years.
Okay.
Thank you.
Thank you very much.
Thank you.
Any question in the room? So we're going to continue with Professor excuse me.
This may be a challenging question, and I say it with the most respect. Hamid and I are colleagues in Minnesota, and it seems like every 6 months he has a new review proposing maybe different target, different stimulation, different protocol. So for me as a clinician, I don't know what to do with this because the technology is advancing so quickly. Are we stimulating? Are we inhibiting? Do we do 5 sessions every 1 week every month? We do 5 sessions at first and then 1 session every week thereafter. And it evolves much faster than clinical research does, because clinical research is very slow. It takes a long time. So by the time you do a research study using one protocol, the field of neuromodulation has moved on. Do you have recommendations of how we resolve this issue so clinicians like me can know what to do with the potential of neuromodulation?
Yeah, I would say that, for example, Colleen and I have had the same issue talking about this, and Ahmed as well. He prefers the ventromedial prefrontal cortex. I prefer the dorsolateral because for me, what I say, you're still stimulating the same circuits. It's just better placement. I think you're right. Everything is, we're trying to find better targets every time. So I would say that it won't improve so much that it won't work for the patients that you have right now. So using dorsolateral prefrontal cortex, it still works. Hamed will say that individualized stimulation targeting is actually improving much more the outcomes. And I would say that it's still not enough to say that you have to do a resisted fMRI every time you have a patient, because it's very expensive in some settings. So something cheaper should come. And the same with, I compare it to muscle exercises. I mean, people do it wrong and still get results. I mean, if you don't do other drugs, but still you get results. It means that even if you're doing it kind of wrong, you will probably get results because you're stimulating sort of the circuit. That would be my take on it. So I guess in summary will be keep doing what you're doing and wait for it to be more evidence to change, because we have solid evidence with this target, dorsolateral prefrontal. We have solid evidence with 10 hertz, 15 hertz. I don't think, like, for example, the European protocol that you're using now with, based on the studies by Matteo Terraneo, are with cocaine. So are we using that for alcohol? I don't know, but we are using it for alcohol, and we're seeing that it is working in the clinic, but the patient relapse again. So is that a win? I would say that we need to go more into, like you said, asking the patient and really seeing the patient. Like, for example, maybe if the patient is saying, okay, I'm getting craving, so that means they will probably relapse again soon, with or without the TMS. Maybe you do a rescue TMS or something like that. And yeah, that would be my take. So I would say wait a bit more, because things are moving fast in research, but it doesn't matter. It still works. I hope it helps.
I would just like to comment on the same question.
Of course.
Well, you know that with ECT, you have it already for almost 100 years. And still there are several different protocols. And they all work quite well. And in the case of TMS, you also have several different protocols, because you can hit the circuitries at different points, and you can do the same effect. And the question is how you individualize the treatment. What we learn in the recent studies, more and more recent studies, is that there is some individual differences. And I think that the fact that there are several protocols and several technologies is actually going towards individualization of the treatment to maximize the efficiency and to increase the percentage of people that respond. But like with ECT, most of these protocols work. You can hit the circuitry, the pathological circuitries in different points and still get very significant effects. So this is another consideration of this discussion.
Thank you.
Any other comments? Okay, so Abraham, maybe it's your turn if you want to come to the tribune. So may I present Professor Abraham ZANGEN. He's well known because he's the co-founder of the Brainwave company, which is very famous for the helmet and for going deeper within the brain. So it's a great honor to have you today in Biarritz. But Abraham is also a professor of neuroscience at Ben Gurion University. So we are very pleased to hear you about the cue-induced craving in RTMS treatment for addiction. Thank you, Abraham.
Thank you very much for inviting me. So I will not speak too much about deep TMS. I was requested to speak about cue-induced craving in TMS. So I will talk about deep TMS, but not about the differences in the protocols. The question, I think, is how much do we really need in the procedure to use cue-induced craving prior to the stimulation. This is the main topic of my talk. So how do I move the green one? Okay. Okay. Yeah. So just as a matter of some introduction, yeah. So first, actually, we started our work in animals. My lab is still having a lot of animal research, not just humans, where we asked the question of whether stimulation of specific brain regions can alter behavioral outcomes in addiction models in rats. And we measured glutamatergic changes in the rat brain following multiple sessions of stimulation. So this was one of the first published studies in the field that we published in the Journal of Neuroscience back in 2007, and found several glutamatergic receptor alterations induced by multiple stimulation, or even expression of BDNF, which was altered by TMS-like patterns of stimulation when you implant electrodes. And these changes were not long-lasting. If you do a single session, you do not induce lasting molecular changes. Only when you do multiple sessions, repeated stimulation over days, you get these stable changes. The same is, by the way, true with ECT that we mentioned just now. If you do a single ECT, you don't get long-term effects on the molecular alterations in brain circuitries, but only when you do multiple sessions, you get the clinical and the long-term molecular effect. So the first studies try to establish these mechanisms of neuroplasticity induced by multiple sessions of stimulation. And in more recent studies, there are indications even for myelin plasticity changes. And the myelin plasticity changes I will talk a little bit about and more towards the end of my talk. Another concept in the idea of brain stimulation for treatment of addiction is that prior to the stimulation, you want to engage the pathological circuitry, because we know, again, from animal studies now today, also from human studies, that an active circuitry is more liable for change. I will talk about this a little bit more in the next few slides, but here is just a summary actually from Colin Henlon, showing from various studies the brain areas that are activated in response to cues associated with different drugs. So it's true for both alcohol, cocaine, amphetamine, nicotine. When you present cues associated with the drug that produces craving, you see in different groups of researchers the same areas coming again and again. It's the medial prefrontal cortex, anterior cingulate cortex, the insula, sometimes also the dorsolateral prefrontal cortex. These are the areas that are activated by cue-induced craving. So this is what you want to target if you want to change the circuitry, the pathological circuitry associated with craving. Although, as we just mentioned, the stimulation is not just trying to change the effects of the cue on craving, it's also trying to affect inhibitory control processes, which are more associated with dorsolateral prefrontal cortex. So why do we want to use provocation? First, from very basic science in animals, we know that items that are stored in long-term memory are becoming more prone to change upon their retrieval. Any memory you have, right, is stable. And if you want to change that memory, you have to retrieve it. You have to recall it, and then you can change it, right? The memory will not change if you don't recall it. And there are a lot of studies in animals showing molecular and electrophysiological correlates of that. So in order to change a memory, and addiction is a type of a memory, you have to retrieve the memory in order to change it. One of our earlier studies by Steberg et al., that again in animals, it was actually a model for aversive memory, conditioned taste aversion, is where we stimulated the areas in the brain that are known to modulate the aversive memory of a taste. And only when we retrieved the memory, we gave the rat the taste that is associated with the trauma. This is the conditioned taste aversion. You give them, for example, saccharin, and then you inject lithium chloride, and then they have the diarrhea, and they vomit, they feel like intoxicated, so they will not touch saccharin again. But if you bring that memory and do the stimulation into the taste cortex, it's a granular part of the insula in the rat, then you can abolish this traumatic memory. So this is what we found. When you stimulate that same region of the taste memory without first retrieving the memory, then you don't get the effect. It's only when you combine the two, you bring up the memory and you stimulate with an electrode is when you get the effect. And then when we translated this in a human study in post-traumatic patients, this was published back in 2013, we had 3 groups of patients, either receiving the TMS daily for 12 sessions with a recall of the traumatic memory of their post-traumatic memory, or without the recall. So you see here that only when we combined the recall of the traumatic memory, a brief exposure of that memory, and the active stimulation is where we had a reduction between pre and post of the symptoms, of the PTSD symptoms. The same stimulation without the recall didn't have a significant effect. Sham stimulation, just the recall, the brief exposure itself didn't have a strong effect. Only the combination had that effect. So this is very clear results in the case of traumatic memories. However, in the case of addiction, we don't get such clear and strong effects. And this is what I'm going now to present to you. So just for the sake of understanding what's the rationale between it is, again, the rationale behind it is that an active circuitry in the brain is more liable for change than a resting or a sleeping circuitry. So we want to activate the circuitry, we want to activate the craving or anything related to the pathological circuitry of addiction, and then provide the stimulation in order to be more specific and make it more liable for change. And indeed, in the case of OCD, there is an FDA-cleared protocol for deep TMS to target the anterior cingulate and medial prefrontal cortex. And this protocol involves first activation of the pathological circuitry by provocation of the symptoms in the patients. And this is tailored for each patient. This is the actual FDA-approved protocol for deep TMS in OCD. Also, the study that I will briefly show you on nicotine addiction, which led also to an FDA clearance for deep TMS in the treatment of smoking addiction, involves cue-induced exposure. And for TMS, there is not yet an FDA approval, but as I told you before, there is a very clear proof, not in a big sample, it's not a multi-center study, a big one that led to FDA approval like we have for OCD and nicotine addiction, but in the case of PTSD, actually the proof is the strongest in a small study that only the combination of the treatment works. So now, what do we have for TMS in addiction? I will go very briefly for deep TMS idea. The idea of deep TMS, if you want later on, we don't have time now to get into the details, is to have unique shapes of the coil where we induce summation of the electromagnetic field in the brain by having a more widely spread wire preparation, plus removing radial components of the coil that produces a fast reduction of the field as a function of distance. So the idea of the coil shape is actually capturing two features that we learned by first by simulation, later by phantom brain measures, that the shape of the coil really can be modified in order to reach much deeper and larger volumes of the brain. And here you see in a figure simply the regular figure of 8 coil and the electric field that is measured in the phantom brain as a function of distance from the coil. So you have a phantom brain, you put a pickup coil inside, and you use, you just simply measure the electric field induced by a pulse, and you see at different distances from the coil what is the field. So in the case of the figure 8 coil, if you use 120% of the motor threshold, which is about, motor threshold is about 100 volts per meter. For those of you who don't know what I mean by motor threshold is the intensity of the pulse that will make your hand move. So if I put the coil over your motor cortex and I click the button, I make your hand move. This is 100% of motor threshold. It requires about 100 volts per meter. And according to safety guidelines, you cannot use more than 120% of that threshold. So starting at 120%, if you go 3 centimeters from there, as you see here in the figure, already in the figure of 8 coil, you lost already close to 50% of your field. So it's below the threshold. It's not functional. It's much lower than the threshold. With H coils, the deep TMS coils, the reduction of the field as a function of distance is much, much slower, and therefore even at depths of like 3 centimeters using 120%, you're still above the threshold. You're still getting significant stimulation. And here you see it in simply in coronal slices. The red pixels are showing you where you have 100 volt per meter. That's, again, the intensity that requires the threshold to produce a functional effect, like moving your hand, in different parts of the brain. So you see with the figure of 8 coil, you have a focal stimulation, but it's very superficial. And with the H4 coil, for example, you have much larger volume of stimulation and deeper. Also, you know, the orange pixels, the yellow pixels are producing something, right? They do produce, say, 80 volts per meter. It does induce changes in the circuitry, but we know that action potentials, large population of action potentials, like making your hand move, is something that is more likely to induce a lasting change in the circuitry when you do induce action potentials in millions of neurons, obviously. So that's a very, you know, brief lecture of an hour in 1 minute about deep TMS. Now, when we wanted to first go for addiction at the beginning, I actually did a study with a figure of 8 coil. There was some effect. It wasn't very strong, but I will skip that. I will go directly to the study we did with the H coil, with the deep TMS coil. That was at the same time when there was a science paper coming out showing that people that had stroke that involved the insular cortex and were smokers before stopped smoking. And people that had stroke in other brain regions do not stop smoking. So we know that the insular cortex may be associated with smoking addiction. And this coil, the H4 coil, targets the insular cortex, along, again, with the dorsolateral and ventrolateral prefrontal cortex. As you see, the stimulation volume is very large. So we compared 3 different groups, one receiving high frequency, 10 hertz, other receiving 1 hertz, low frequency, and the third group receiving sham stimulation. And each group was subdivided into 2 groups, one having a provocation just prior to the stimulation every day, and the other one without the provocation. So this was a randomized study with many patients, but it's subdivided into 6 groups, 3 times 2. So the numbers eventually are much smaller, and the results were very interesting, I think. When you look at the reported number of cigarettes they smoke, you see here how much they smoke over time. So you see that those receiving the high frequency had a greater reduction in the reported smoking, but there was no big difference between those who had cues provocation for smoking, which takes a few minutes. You know, you get them a cigarette to handle, to smell it. You give them some provocation videos. The craving is measured. It is increased, but there is no big difference between those who received the provocation and those who did not receive the provocation. You see, there is better effect with the provocation, but it's not significant. It's not like what we had in the PTSD study where it was very clear cut, okay? And here we even see some effect of the 1 Hertz without the provocation. But fortunately, we cannot only be dependent on the reports of the subjects. We have to take some objective measures, and that's what we did in this study. We had urine samples taken every week, and we measure cotinine. Cotinine is a metabolite of nicotine. And here are the results of the cotinine. So when you look at the cotinine, creatinine levels, you see that actually this 1 Hertz effect is not very strong. And the most significant one is, again, when you use the high frequency plus the provocation. So this, and here you see the time course of these cotinine measures. So taken together, these measures, when we decided to go for a large, very expensive, multi-center study that involved several sites, mainly in the US, some also in other countries, we decided to go for the high frequency with the provocation. That's how we did the multi-center study. Here you see, by the way, quitting rates. The quitting rates were much, quit rates is defined by both the report and the cotinine. And you see that the strongest effect is when you do the high frequency plus the provocation. Now, when we did the multi-center study, these are the centers that were involved. In Columbia University with Diana Martinez as well, Morales in McLean, Harvard, and many other distinguished sites that were involved in this study. We used the 10 Hertz with provocation versus sham with provocation, of course. The sham group also received the same provocation, but sham treatment. By the way, the sham coil is encased in the same helmet, okay? It's inside the same helmet, and so that, and there is a magnetic card that determines whether the active coil is activated or the sham coil is activated. So the subject doesn't know whether he's receiving or she is receiving an active or a sham. Of course, the raters do not know, and in many cases, even the operators do not really know. Now we have even better sham coils that it's even hard for the operators to guess sometimes which treatment is given. So in this multi-center study, as you see, the recruited patients were very severe. These are all patients that tried to quit smoking before, with medications, with nicotine replacements, with psychotherapies. So these are heavy smokers. The criteria was that there should have been heavy smokers that failed previous treatments. We had 60% of them that failed at least 3 attempts. It was not a criteria, but eventually post-hoc analysis of the data showed that close to 70% failed 3 serious attempts to quit smoking. In average, they had a pack per day, although we had some subjects with 3 packs per day. 27 or 26 years of smoking, you see no differences between the active and the sham at baseline. Measures, 262 patients altogether in all the sites were recruited and allocated to the 2 groups. And these are basically the results as published in World Psychiatry. You see that no matter if you look at the ITT cohort, the completers, there is short follow-up after a month. There is long follow-up. The criteria for quitting is that you have clean urine samples for at least 4 weeks and reported no cigarette smoking, 0 cigarette smoking and clean urine for 4 weeks. So as you see, the difference between active and sham is very clear in any cohort that you look at completers or ITT. In the short term or the long term, which is after 4 months, the rates of quitting is not great if you really look at the numbers, you see. But the numbers are so small in the sham group. We're talking about very heavy smokers who weren't able to stop smoking before. So you see that numbers are very low at the sham group and 3 times better in the active group. So now to the issue of our presentation. Did we really need the Q? We didn't measure it in the multi-center study. You know, a multi-center study regulated by the FDA is very expensive, and the company that financed the study didn't want to invest in more and more groups or measurements like I do in other studies where I do fMRI and EEG, which are measured, are funded more by the academy, by the government, and so on, not by the commercial company. So we only had 2 groups, and another post hoc analysis of this study actually looked at the effect of Q-induced craving on the outcome. And this is a very recent study now in press that actually seemed to show that there is no association between the magnitude of Q-induced craving and the eventual outcome of quitting. So those patients who had greater Q-induced craving effect over the time are not necessarily those who quitted, okay? On the other hand, this measure is not really telling us very much, because obviously if this is measured over the whole course of the treatment, those who had greater Q-induced craving means that the treatment did not really affect them. Moreover, it doesn't tell us whether you need or not need the Q-induced craving, because it's only telling you whether a greater magnitude of Q-induced craving produces better chances to quit. So it's not a direct measure of this question. In order to really measure it, you need to have a clear study where you compare a group with the Q and without the Q and then compare the outcomes. But there is a hint from this study that greater induction of the Qs did not produce greater effect. And another hint from this study is that you see that the Q-induced craving is quite stable over time. So you see over the 15 sessions that always the red line, which is the visual analog scale, you ask them how much do you want to smoke right now, okay? Before and after. Visual analog scale 1 is before the provocation, VAS 2 is after the provocation. So you always see higher craving after the Q. So the Q do produce some induction of craving as reported by the patients, and this is stable over 15 sessions over the whole, every day. We do it every day, and it works. So the Q-induced craving procedure works and is stable, but we don't see a correlation between the magnitude of the difference between VAS 1 and VAS 2. This is what we call the Q-induced craving level magnitude. No correlation between this measure and the eventual outcome of quitting. Here is what I just said in numbers. So this is like trying to look for these correlations between the Q-induced craving magnitude and the eventual outcome of whether you quit or not. On the other hand, as we published in the same study where the FDA approval study was published, then you see here that the effect of TMS on Q-induced craving is a very interesting effect. First, let's just look at the effect in the first session. So this is level 0 is the craving for each patient before the first treatment. And then what you see here is the Q-induced craving, increase in the Q-induced craving, both in the sham and the active group. Both of them receive the Q, and they have an increase in the VAS 2. Now, when you measure VAS 3, that means after the TMS session. So the TMS session takes 20 minutes, and of course, there is a reduction in both groups relative to the Q-induced craving because we don't do a Q again. So after 20 minutes, there is a reduction. The most important question is whether the craving is reduced versus baseline. This is VAS 3 minus VAS 1. That means after the TMS versus baseline. So here, the sham does not have any effect. The sham stimulation, in average, of these 200 patients in the study, did not produce any reduction in craving. The active stimulation in this multi-center large study, many sites, big study, I think it's the biggest study showing the TMS, at least deep TMS, with in this case the H4 coil, was able to reduce very significantly the craving relative to zero effect of the sham stimulation. This is the results simply in the first session of our multi-center study. But I think the most striking, for me, it was the most, the happiest moment in my, research for this study was to find that there is a correlation between the reduction of craving induced by the TMS and the eventual quitting 4 months later. So the first day, if the deep TMS was able to reduce your craving, could predict on whether you could stop smoking or not. This was very significant, and very interestingly, it is significant in the active group, but not in the sham group, okay? So the association between VAS3 minus VAS1 and the quitting eventually is significant only in those who receive the active treatment. So this for me was very exciting. Still, it doesn't tell us that the cues are necessary. It's just telling you that if TMS is able to reduce the craving, it is likely to induce quitting of smoking. Finally, I want to tell you a little bit about the alcohol studies that are more recent studies in my lab. We actually my lab was first established at the Weizmann Institute, then I moved to the Ben Gurion University. These very initial studies were never published, but the ones that are published I'm showing you today are already done in the Ben Gurion University. So here you see a randomized study that compared the effect of deep TMS targeting the anterior cingulate cortex and the medial prefrontal cortex. This was done in a consortium. Markus Heilig from Linköping University was also involved in this study. We had 2 sites, and we evaluated both medial prefrontal cortex stimulation and insular stimulation. Basically, this is not the topic of our lecture, so I'll not get into the details. Just tell you the bottom line, that the finding was that insular stimulation was not superior to sham, but medial prefrontal cortex and anterior cingulate cortex, the H7 coil, was superior to sham. In this study, also we had the cue-induced craving. Here, the procedure was that each patient had to tell us what is the favorite drink they like, and we bought that special drink for the patient, and we poured the drink into a glass. We gave it to the patient prior to each daily stimulation session to smell, and then we put the glass with that favorite drink in front of him on the table. So the full half hour of session every day, which included 3,000 pulses, 10 hertz, the same parameters that we actually started back there in animals and translated to the humans. The same basic parameters of stimulation were used. 100 sessions, taking half hour, and 3,000 pulses. While this glass of favorite drink is in front of the patient, he's not drinking it, but it's really provoking. 2 groups, one sham, one active. So we don't have it with or without the cue. 51 randomized. We had eventually only 23 in each group that survived the treatment. That means 3 weeks of treatment. Each day 3,000 pulses is 15 sessions. And then the most important part is the measurement of how much they are able to stop drinking. The criteria to get into the study was that you are an alcoholic and you can stop drinking at least for 1 week, because we don't want them to be in acute withdrawal. There is some risk when you are in acute withdrawal of drinking that if your C1 measure, it's a measure of acute withdrawal, is high, you might get a seizure by the TMS. So they have to be without, symptoms of acute withdrawal from alcohol, 1 week. So these are patients that were able to stop drinking at least for a week in order to enter the study. And if they drank during the study, during these 3 weeks, they were kicked off the study. So the day 0, the end of treatment, are those who were able to not to drink for the first week and then for the 3 weeks of stimulation. We had some dropouts on the way, but now the question is, after 3 more months, we want to know after 3 more months how many of them are still not heavy drinkers. This is, by the way, again, now before I showed you a map of the H4 coil, this is the H7 coil, which targets medial prefrontal and anterior cingulate cortex. The way this is used is actually, instead of stimulating the hand, you stimulate the foot. The foot is represented deeper into the brain, right? It's not so easy to get foot activation with a figure of 8 coil. With the H7 coil, it's quite easy. And then this threshold for making your foot move is the threshold that you use for these patients, because it's about the same depth for the dorsal part of the anterior cingulate as the leg. You just move the coil 5 centimeters forward, and then you activate the coil. 3,000 pulses per day, 3 weeks of stimulation. And here we had fMRI measurements before the first treatment and after the last treatment, after the 3 weeks. And of course, we had urine samples to verify that they are not drinking every week, and craving measures, and we also had DTI and EEG. This was a very large, more basic study with lots of neurobiological outcomes. So first, the clinical behavioral outcomes that you see here of the study, published in Biological Psychiatry. Reduction, as you see, is very strong in both the active and the sham group. We are talking about patients who are able to stop drinking in order to enter the study. So of course, there is a reduction in drinking, there is a reduction in craving, and you see the first, after 3 weeks of treatment, this is follow-up 1, after 3 weeks, they're very low. The question is how much they can be stable, sober for 3 months. So follow-up 2 is after another week, 2 weeks, 1 month, 2 months, 3 months. So what you see here is that in the sham group, there is a gradual increase in their drinking. In the active group, it's more stable down. And this effect is significant. There is a significant difference between heavy drinking days in the active versus the sham group. This is the number of alcohol consumptions, gram per week, over the 12 weeks, okay, after the, so again, you see that the active group is much better. This is the objective measures, urine samples, positive versus negative urine samples. Again, you have more positive samples in the white bars, so that means the sham group drink more. And you see here that the craving, which is strongly reduced already from baseline to week 1, you see that this baseline reduction from baseline is very strong, both in the active and the sham, but it continues to go down during the 3 weeks of treatment, but not in the sham group. And if you go then for the follow-up phase for another 3 months, then you see a more increase in the craving over the 3 months, but stable, quite stable, low level of craving in the active group. Okay, I think there is a loss of a slide here. Yeah, so there is a loss of a slide. In that paper, we also looked at the functional MRI connectivity, and we found reduction of connectivity between the anterior cingulate cortex and the subgenual, the dorsal part of the anterior cingulate cortex and the caudate, and between the medial prefrontal cortex and the anterior and the genius cingulate cortex. So this slide is missing from here, but you can see it in the published paper in Biological Psychiatry. So we also found some neurobiological correlates in fMRI. The more recent study, which analyzed DTI in this cohort, replicated the previous notion that during acute withdrawal, there is reduction in connectivity as measured by fractional anisotropy by DTI. We know that fractional anisotropy represents connectivity and myelin pathology. And over time, during acute withdrawal from alcohol, during these 3 weeks that we measured before and after, right, we see this reduction in both active and sham group. In both groups, we see that there is reduction in fractional anisotropy representing myelin connectivity in the brain following withdrawal. However, when you look specifically at the area of the stimulation here in the medial prefrontal cortex, the area of the stimulation, this reduction was halted. So this is the sham group, this is the active group. The sham group, you see this, the reduction during withdrawal. In the active group, it was halted. And then you can take reconstruction of axonal tracks from the white matter regions showing the preserved fractional anisotropy values. So by reconstructing of these tracts, you can look further, not at very traditional fMRI measurements of connectivity, but looking specifically at regions of interest. And here we found additional alterations in connectivity induced by the stimulation, active versus sham. You see that there is an increased positive functional connectivity in the active TMS versus the sham between the temporoparietal gyrus when taking the seed and the dorsomedial prefrontal cortex based on this reconstruction. And also another change in connectivity, increased negative functional connectivity between the medial frontal gyrus when the seed is the preconeus over here. So we found additional neurobiological alterations at functional fMRI resting state connectivity following the reconstruction of the understanding of the changes induced by according to the DTI. Okay, now last slide of data, which is the most recent publication, just very recent, from 2025 in biological psychiatry, is the EEG in these alcoholic patients. So we know that in alcohol use disorder, patients are reported to display modifications to frontal beta activity relative to controls. And here we had the opportunity to look at this EEG changes before and after the 3 weeks of treatment. And again, like what we found in the DTI measures, that we halted the reduction in myelin connectivity, here we see that we halted the reduction of beta activity at rest. In the upper panel, you see here is the sham group. During the 3 weeks, you see a reduction in the beta activity, but this was halted and even increased by the active stimulation. Not only that, again, the prediction issue, you can see that if we compare patients who relapsed versus those who did not relapse, so in the active group, those who received active treatment, patients that had higher beta at baseline were those who are more likely to not to relapse. Okay, those with lower beta activity are those who relapsed. You don't see this in the sham group. This association between beta activity level at baseline and yes or no relapse was only true in the active group. And finally, if we look at the TMS evoked frontal beta power, so we have these EEG measures before, during, and after the first session, and before, during, and after the last session. Just looking at the first session, the beta activity is increased by the active stimulation more than in the sham, but more importantly, those who showed increases in their beta activity induced by the TMS are those who were benefited from the treatment, those who did not relapse. So the ability of TMS to increase beta activity during the first session predicts the ability of the TMS to prevent relapse later on, during the follow-up period. And again, this finding is not shown in the sham group, it's shown only in the active group. You see this finding? So these are those who did not relapse, have an increase in their beta activity. This did not benefit from the treatment because the TMS was not able to induce beta activation. In the sham group, you don't see this phenomena. So with this, I will end my talk just in conclusions. So first, to summarize what we are talking about, provocation of symptoms may promote TMS treatment for drug addiction and other disorders. And I say may, we don't have a definite, proof for that. We have somewhat definite proof for this in the case of PTSD, but in a small sample. The response for provocation during initial session may predict the clinical outcome, as I showed you. And the magnitude of the cue-induced craving in the nicotine addiction study remained quite overall stable throughout the treatment sessions, but was not correlated with the quitting eventually. So therefore, I say we still need future studies to really find out if cue are necessary, absolutely necessary in order to be successful in addiction studies. We have a hint for this. My personal, I say, take of this is that it's better to do it. We have more evidence with it, but it's not very strong as we have it for the case of PTSD. Future studies should really explore whether the effect of provocation are mediated through interaction with craving or inhibitory control. There are still many unknowns, but the treatment works for smoking, for alcohol, and we are now starting a multi-center study to replicate this finding like we did in the nicotine study. We first had a feasibility study with all these 1 Hertz, 10 Hertz, with and without provocation. Then we had 2 groups. Now we are also going to have these same 2 groups just with the provocation and a multi-center study with FDA regulation in order to hopefully replicate what we found earlier and get a first FDA clearance for TMS in addiction, in alcohol addiction. That's it. Thank you very much. And of course, I have to thank all the collaborators. It's not only me here. Marcus Heilig and Santiago Canals for the DTI. Mayan Harel was a PhD student in my group now, postdoctoral fellow. And of course, those who were involved in the multi-smoking, multi-center study. And thank you for listening.
Thank you very much, Abraham. So we have time for 1 or 2 questions, no more, because time is running.
And we crave to hear Chris Bacon.
Yes.
So, hi. The last data slide you presented with the EEG findings, how soon were the signals for the EEG noticeable? In other words, could it be used as an early indicator whether to abandon therapy or to keep moving forward with therapy?
So we only measured it in the first session and the last session, right? It's quite complex. We have 64 electrodes. It takes a lot of time consuming. So we only have prediction based on the first session. In the first session, in order to really establish a stable signal, you need resting measurements for at least 5 minutes. And then you have, during the session, we take measurements, and then 5 minutes after the session. So all I can tell is that these 5 minutes that we measured resting state activity before the sessions, or the evoked beta activity during the session, were associated with the success of the treatment. We cannot say anything more than that these 5 minutes were enough to be statistically significantly predicting whether you're going to respond or not to the treatment.
Hi, great talk. I wanted to ask you about what you think. So about cure activity, we still haven't done it because of the evidence. I'm not leaning into it too much. However, I want an excuse to use it. And one of the things I was thinking about was, so when you do cure activity, you basically, for example, the alcohol, you subject them to the craving. What about, so we were stimulating the dorsolateral prefrontal executive control. Would it make sense to do a task instead, so they're seeing, for example, let's say videos or photos of use, of cocaine use, and then you ask them to try to avoid, the craving, for example.
Right. So you're talking about reappraisal approach, right?
Yes.
It's called reappraisal. And this wasn't tested. It's a very, I think, very interesting study to do. And as you asked before, there's so many things to ask and do, and each study like this can take years.
Yeah.
And each little change in parameter can make, but in theory, this makes sense, especially if you want to target not the craving, the cue-induced craving, you want to increase the inhibitory control circuitry. So you should do this type of reappraisal and see whether the stimulation can enhance that. It's a beautiful idea. I'm not aware of anyone who did such study yet with any coil.
Okay, so we'll see. Thank you.
A good grant to write.
Sure.
Any other questions? In French, eventually? Yes, Jean-Pierre.
Thank you for this excellent presentation, but two short questions. First, at what moment do you give the cue? Before to start the stimulation or during the stimulation? First?
Yes. So in the alcohol study, as I said, is before the session, but the glass of the favorite drink is on the table in front of the subjects for the whole session. So it's starting before the session.
During
but it's
the
there
whole session?
During the whole session until the end. That's in the case of the alcohol. In the smoking study, there is no way to do it. We do it only just before the session. And actually, this is a very good question. I don't know if we have really time to get into it, but because what we do in the stimulation, we open a window of plasticity. It's a window of opportunity to change the circuitry. Yeah. And you don't want to do provocation after the session if this window of opportunity was used to normalize the system, to reduce the cue-induced craving, and now you produce another cue, you might cause a negative effect or an opposite effect. So, and we know from stroke studies, it's not my studies, from other groups doing stroke studies, that if you do, for example, after motor stroke, if you do rehabilitation, if you do the rehabilitation before the TMS in order to enhance, the rehabilitation and enhance plasticity, so you do the rehabilitation and then the TMS, it might destroy the effect of rehabilitation. So they recommend to do the motor rehabilitation after the TMS because the TMS opens the window of opportunity and then you do the, all kinds of motor physiotherapy and all these things. Right. So it's a good question, and that also requires studies. I don't know of anyone who did cues after the sessions. It might even cause an opposite effect.
Okay, perfect. Second, in alcohol, you explained that I understood that it was because the research need you only treated the alcohol abstinent patients from 2 or 3 weeks. Yeah. But in clinical practice, in our daily practice, it's very difficult to have abstinent alcohol patients. And if they are not very huge alcoholic disorder. So, in your opinion, it's possible to treat patients with having
wild drink
before?
Yes. This is a great question, and actually Marcus Heilig was going to be the co-PI of the multicenter study, suggested that in the multicenter study, we do it that way. We don't request the patients in the multicenter study to stop drinking. So we have this risk of seizure, and therefore we measure CWA every day, and if the CWA is above 6, then they are at risk of a seizure, then we don't treat them at that day. They lose that treatment day. So in the multi-center study that we are now going to start very soon, in a few months we start several centers, mainly in the US because it's an FDA regulation, we are going to have patients that are still drinking. So we will know the answer to your question in 2 or 3 years.
Perfect.
Yeah.
The next Biarritz meeting.
Yes, yes. Chris BAEKEN is going to present now his data about the use of rTMS in alcohol use disorder. So I'm realizing that we are all specialists of the field of rTMS, and it's a little bit confusing for, maybe for people regarding the different targets that we used. Chris, thank you to be there. It's a great pleasure to welcome you. Chris BAEKEN is hugely involved in rTMS for a while. I met him several years ago, 10 years, so 15 years ago. It was in Gand, and he created the European Association of Brain Stimulation with some friends of us. So thank you very much. It's an honor to welcome you in this beautiful city of Biarritz, Chris.
I couldn't have said it really better, Bruno. So thank you also for the organizations, a committee to invite me, even if we have a big storm coming ahead of us tomorrow, apparently. So that's the only relevant disclosure, I guess, that I have for the moment. The other, they are already said. I'm going to talk you through as quickly as possible some of the things I think you have already heard. I want to avoid some kind of the repetition. And I'm only going to focus this time on alcohol use disorder, or alcohol addiction, in fact. And I'm also going to talk about our protocols that we have done in the past about accelerated TMS in alcohol dependency a couple of years ago. As you know now in the field that accelerated TMS, and certainly for depression, but also for other neuropsychiatric disorders, is really into the mode, if I may say it like that. And I hope to have some kind of a discussion. Maybe some of the questions already posed, but I hope that this can enlighten a little bit furthermore. Just to the entrance here, if you think about, I was thinking about the talk that I would do today is about depression, it's about alcohol disorder, but if we see it from what the possibilities for TMS are, that over the time you find more and more evidence to use it in a lot of neuropsychiatric disorders, psychiatric disorders, ranging from major depression, OCD, even negative affect PTSD, a negative effect for schizophrenia. But for addiction, the guidelines seem to be stalling, and they're not really going in the direction how and when to use TMS protocols for a given addiction, as already commented on in the aula here. So we are using mostly the European guidelines or the Le Faucheur guidelines, and we had one round in 2014, the other already in 2020. We should have a new one, but there is no recommendation in the guidelines for the moment if you use TMS for alcohol alcohol craving, because this is my talk. Let's see, it doesn't work that well. The only thing is a possible effect of a level C. So that means that there are some, as also Professor ZANGEN alluded on, there are some evidence that for cigarette craving, it's now a possible in the guidelines. For those who are not familiar, because people are going to talk here about high frequency, low frequency, left and right, it's just a small interludium, a small reminder of how that we come to the fact that we only stimulate these two areas, and it comes again about the most investigated clinically, but also on research, is on major depression. It's also based on very old and very simple ideas. When you're clinically depressed, you have prefrontal hyperperfusion, mostly on the left if you compare it to the right. It's more complex than that, of course, but this is the start of the field for TMS in psychiatry and depression, to stimulate it to the left, to excite with high frequency of intermittent theta burst, and it's now a new protocol, or you're going to inhibit, or you're going to suppress it by low-frequency TMS, mostly on the right side. And this is, of course, taken over for a lot of other psychiatric disorders, including addiction. We do know for a moment that for addiction, and this is just a repetition, that there is some evidence for alcohol that there could be also a place for TMS, but certainly not if you are using it once, but you have to use it at least 10 times, and if you want to have an effect on craving. There is an issue, of course, of maintenance. What does maintenance mean? You have to think about if we do the protocols of accelerated, or if we do it on 10 days, or we do it on 20 days, it's always an acute protocol. And after that, it stops. So the question for all of us and all of other psychiatric disorders, even if it has a success and even if it has a remission, what would we do afterwards? Because we do know, and certainly also for alcohol addiction, it's a chronic course mostly, and people tend to lapse and to relapse in the future. So there is no real notice now, no real evidence how that we would use maintenance treatment in alcohol addiction. We do not even know it 100% for depression. And the other part is the targets. We have heard it also for the two other speakers. Where we do stimulate, how do we stimulate? It's a little bit of, let's say, growing knowledge. And that's also the reason, I guess, that the question came of the audience, why it takes so long that this is picked up in guidelines and that people can use novel and more effective treatments. It's a very slow process, as has been set out. And it's a very strange thing because we have another non-invasive brain stimulation method, which is transcranial direct current stimulation, which is mostly less potent for any other psychiatric treatment, as for depression or OCD or whatever, but it seems to be that it has a better effect also in the guidelines, also already from 2017, for craving. And not only for alcohol, but for a various amount of addictions, of this cocaine, methamphetamine, or whatever. But you have to change the stimulation a little bit, because now we are not talking about the high or low frequency TMS, now we are talking about anodal and cathodal, which could be considered very simply as the equivalent. So you change it a little bit, and if you're also looking at the effect, what then exactly happens, probably the effect is not only under the electrodes, but it's somewhere in between. And we have also already heard about the ventromedial and the dorsomedial prefrontal cortex, where exactly probably the most effect on electricity is going to. This is, I think, something that I already said. And the reason is, of course, that there is also a lateralization difference in craving. Mostly the right is more on the impulsive part, and the other one is more in the cure activity part, if you also heard before. So what I would like you to talk about is about our studies that we have done in the past about accelerated TMS and alcohol dependency. And I start with giving tribute to Sarah Hermans here, and I'm going to talk, in fact, of 80% of her PhD at the time, about how that she started to investigate the effects of TMS with single sessions on patients with alcohol addiction. So they were admitted to our ward, they did a detox, as you do a regular detox, and afterwards we did them a single session, sham controlled at 30 patients. And we looked at one hand how the craving was and also what the effects was on cognition, on the go-no-go task, on impulsivity. After that, we did find no effect on craving, and also it's not a cure reactivity craving, it's just a passive stimulation session. But we didn't find any effect, but we did find some effects of the go-no-go task. It was very difficult to interpret, but we interpreted at the end that it had some effect on cognition, on attentional control. So people had a little bit more control during the active as compared to the sham. So the question is here, what I'm going to talk about, accelerated. And first of all, those who do not know, what does that mean? It comes again out of the research of depression, And when you think of it, so we are talking about daily sessions, but daily sessions, you have a patient, in this case an alcohol-dependent patient, who has to come to, or is it inpatient maybe, but he has to come to the clinic every day for at least 10 days. That's how we started in the depression 20 years ago, but now the number of daily sessions, it moved away from 10 to 20 sessions, and now more or less the golden standard, because 30 is 30 sessions. Then you need to have every time a patient coming into your clinic to have the treatment, and you need somebody, of course, to apply the treatment. So this is a very logistically difficult procedure, and you need to have a lot of commitment from your patient. And as we all know, for alcohol-dependent patients, is this commitment of this long maybe an issue? There is always a very large dropout rate. And we thought maybe we have to compare it also that what we are doing with depression, and we are going to, instead of doing all these sessions longer and longer, as electroconvulsive therapy, we also had a talk about, a question about that. If you think about it, for depression, you have very severely depressed patients after a couple of sessions, 6 to 12, going from really severe to in remission, 80, 90% in some times. So this is very, very a huge number. And the accelerated TMS, of course, had the idea to concentrate all these stimulation sessions over only a couple of days. And the most important one that we are knowing now, and also Bruno alluded to that one of the founders that sadly passed away, Nolan Willems, they invented the SING protocol, where they do 10 sessions a day over 5 days, and you have response and remission rates that become very close to the electroconvulsive therapy that we have for depression. So we thought at the time, why shouldn't we do that as well for the alcohol-depressed patients? And we took what we have done before. So one session a day, one day is 5 sessions with a 15-minute session interval. For depression, we're doing it for 4 days, so that's 20 sessions. And for the alcohol dependency, we just skip the last one because we wanted to have only 15 sessions over 3 days. And the first one is, again, an experimental fMRI study where we do a sham control study. The number of patients here are not that exhaustive. These are all pilot data, only going in the 30s every time. We did a Q reactivity paradigm. At that time, that's 2013, 2012, at that time, we were not aware what is now the best Q reactivity, so we showed patients a block design and a Q reactivity design, and after that, they received their 14 active sessions. This has no placebo, and we measured them with alcohol use questionnaire and the obsessive compulsive drinking scale. So what did we find? I'm going over very quickly here. So we didn't find for the one session any effect on craving. But after the 14-day sessions, certainly the alcohol urge questionnaire significantly decreased. So we had over time a significantly decrease over the craving part, even when patients at that point were at home. For the single session, we were a bit surprised because we saw that the active stimulation was in one of the paradigms giving an increase of motor-somatosensory parts, like for instance the insula. And afterwards, after the treatment, we found a decrease mostly in the attentional, in the parietal cortex, more the intention parts, that made us say, okay, the effects seem to be not directly related to the reward system, because that was at that time our hypothesis a bit, but it seems to be related to. It was this question that we then proposed also in our paper. But we did the following, because of course you see the craving, but what happens afterwards? So we did only at that time, again, it's a pilot study. After 1 month, we just contacted patients, asking them, you have a lot of methodological issues here, but we asked them, did you relapse, yes or no? Did you start drinking again, or you're still abstinent? That was the yes or no question. And of course, we again looked at our imaging data, and we found that, let's say, 2/3 of the patients relapsed. 86% already said there was a period that they started drinking again within 1 month. I'm not saying after a month, it was within the month. Some people relapse very fast, some really at the end. But this is the relapse part. And what we found for the baseline with the block design, that within the relapse circuit, which we then defined also according to the work of Volkov, we found that the dorsal ACC, the higher the activity during the cure activity, those were the patients who remained abstinent as compared to the relapsers. And we also found, with the second scan, there was some kind of rate-dependent effect that meant that those already that had a high level of cure reactivity in the dorsal ACC, these were the ones who were abstainers. They didn't relapse. And those who relapsed, they had an effect that the effect was increasing towards the abstainers, but it seemed to be not enough. So that meant on the clinical part that maybe for one group of patients, when we're talking about personalization, so TMS, if you're already high in cure reactivity, maybe the additional TMS, right side, DLPFC, I'm not talking about anything else here, is maybe not really the good solution. And for those who had that accelerated TMS, maybe with the 15 daily, the 50 accelerated with 5 sessions a day, these 15 sessions, maybe they were not enough to reach that level of abstinence. And so this means that maybe this, okay, it's an underpowered study anyhow, but maybe the number of treatment sessions were simply not enough. And maybe for accelerated protocols, we have to go, as the depression protocols, to more than 30,000, more than 20 sessions, or more than 5 sessions a day over a couple of more days. So this is the rate dependence effect. What was really insightful for us, that there was some kind of distinction between them. We also looked at the gray matter volumes. That was something that we have seen in depression. After really a relatively short amount of time, you saw neuroplastic effects, mostly in the hippocampus, but we did the same for the alcohol-dependent patients here, and we didn't find any effect on gray matter volume. Of course, it's only after 1 week. You could say, okay, plastic processes need to have more time, but still we found some in the depressed cohort. However, if we were looking at the differences between abstainers and relapsers, it seemed that those who remained abstinent after a month displayed higher volumes in that exact same area, the dorsal ACC. So this was the same cohort, but it was 2 different findings. So let's say for the preliminary findings here, it's still unclear if it can affect craving, but it seems to be that way, and maybe the dorsal ACC is a better target. Some of these data, and certainly for the accelerated TMS, are moving that way. And the rate-depending effect and, of course, the volumetric differences seem to support that. But again, small sample size, it's craving mostly in the lab setting. If you're talking about the single sessions, we have a no placebo control, it's just an open treatment. As I said before, only the target was the right DLPFC. It was one protocol, and we have talked what is the different protocol. This one protocol that we just adapted from the depression research at the time. Abstaining relapse was only 1 month, what's about 2 months, 3 months, maybe everybody relapsed. As well, it was just a subjective way of asking people if they relapsed. And we have no time, if we didn't do a multimodal approach, seeing what effect the combination of the relation is with these volumes and activity changes. We could do that still, but we haven't done that until now. So again, for the discussion for alcohol and rTMS, it's still a little bit of a surprise that the effects are quite, or the guidelines remain quite low. And one of the reasons could be, and I'm not saying I'm going to open a discussion here, but there is a discussion going now in the field, that maybe the people of the field are a little bit more reluctant to do some research with alcohol dependency. Because also in the guidelines in 2020 was already said, if you want to do a combination of your, for instance, patients with mood disorders and they have some alcohol dependency problem, you are treating the mood disorder, not the alcohol disorder. So this is something that is still very living in the field. And we had really a Delphi question and publication in the American Journal a couple of months ago about what to do in your studies, in your clinical research, if you want to treat patients with TMS or non-invasive brain stimulation and have some kind of an addiction. You can do that for every addiction here. It remains more or less the same, also for alcohol addiction. And it's mostly that you should avoid it. And if there is a problem, you should delay it. And if there is really a risk, then you should probably not do it. There has come now also a reaction out of the field, and it's quite justified, I think, that said, okay, but by doing this, maybe you're going to exclude more and more studies that is going to focus on alcohol or substance use disorder. So this is now really a very livid discussion into the field. And again, we have a lot of unsolved issues. I said it before, it's an acute treatment. Even if people get better, we have no idea what to do next. Again, history learns us, and maybe we just have to have more and more studies over the long time, that also we have seen that with electroconvulsive therapy, again, our most potent antidepressant treatment, if I may say it as such. If you do nothing, a relapse rate within a year of 60–80%. So now they are doing, as you know, probably maintenance ECT, or they're doing a combination with clomipramine and lithium over the long time to prevent relapse, to keep people on that level. But we do not know even if we have to do that for TMS exactly, and certainly not for maintenance sessions in alcohol and drug abuse disorders. So I think I'm going to stop here, given the time. I thank you all for your attention, and I would like to take your attention also to our European Society of Brain Stimulation, where we have all of these kinds of discussions. We have also accreditation courses for those who are interested to learn more and being accredited as a trainee center or as a trainee for non-invasive brain stimulation. And every 2 years we have our European Conference of Brain Stimulation. This year it will be, I know it's next year, in a year then. In 2026 it will be in Italy, in Napoli, between 15th and 17th of October. And I hope that a lot of you here are taking the train or the plane to Napoli to come to see us as well. But I thank you for your attention.
Thank you, Chris. Any comments about my co-president? One comment about what Chris said about the co-occurrence of disorder with substance abuse, and is it worth to measure the phenomena per se? What is your opinion about this difficulty to evaluate addiction skills?
Well, it's a big question. Of course, that especially in alcoholism, the dysthymia part affects the outcome. I don't have a good answer on this. I'm sorry. It's very hard to dissect the different effects on the symptoms, on the eventual effect.
Many thanks for all three speakers. I have a question for all three. We have a big problem in France. We have no reimbursement for any indication for ATMS. There has been 20 years of frustration with continuous no answer for this for depression. Do you think indication in addiction would be a better approach for an approval in France?
I go? Well, I will doubt it, to be very honest. I think if you want to have reimbursement for a therapy that works, you have to have the utmost proof for the national health system to be convinced that they are going to reimburse. The problem in Europe is, of course, that it's not a European health system, it's a national health system. And then you see all over Europe, because I see now that you have parts of Europe that it's reimbursed, other parts that it's reimbursed under certain conditions, and some other ones are not reimbursed, as in Belgium and in France. And it's always a very local, national issue. So if you're going for the addiction, I guess, and as I see now how these health instances, how they are going to evaluate that, I would go for the most cost-benefit approach that is evidence-based for the moment. And I'm not saying that it's not evidence-based for addiction, but I don't think it has the same level as it has, for instance, for major depressive disorder. So I would go mostly that way. The only problem that you have, and all of us have, that people are not aware in the field about the brain stimulation differences. They're going to compare to electroconvulsive therapy. But electroconvulsive therapy is, of course, for a certain pool of patients, catatonic depression, psychotic depression, and some others. But this is not our target in the non-invasive brain stimulation, because we just want to avoid, let's say it like that, the psychotic depression, because we know that electroconvulsive therapy is better, but it's quite similar to chronic or treatment-resistant depressed patients, that you see that the response and remission rates are quite close. But that's my opinion.
I agree with everything. Though I think depression and mental health in general is a better approach, because it has higher rates of it's a higher evidence, higher rates of success, and that I've seen also in the clinic. And I think still with the addiction, we're still figuring out what's better. And I think it's a better sell point. However, I mean, I don't know in France. I know in Mexico, we don't have it as a part of the national insurance. So, and even insurance companies don't compensate. So it's done as an outpatient clinic and out of pocket.
I think it will change once it has FDA approval. So, you know, there is FDA approval for depression for many years in the US, and therefore there is reimbursement in the US for depression. There is no reimbursement for addictions, even not for the smoking that already has FDA more recently. But I think if we will manage to get an FDA clearance, then it will affect, because eventually alcoholism causes death, car accidents, and so on. And for the insurance companies, it might worse to reimburse treatment more than to pay for the consequences of loss of life and work days and so on. So I think once it has stronger evidence with FDA approval, usually is an established multi-center study, it will be maybe possible to get reimbursement in Europe as well.
Yeah, I have a question. What happens if a patient has dual pathology like depression and then substance use, can you get reimbursed or not? Even if it's for the depression? Yes. Okay, that's interesting. Because you never get a pure patient with only substance use and that's it, which is, what do they do then? They just give pharmacological and that's it, or? Yeah, the question is, yes. if you get, like, because you always get a patient with either depression, anxiety, and a substance use, so whatever you do to that patient, it has to affect, both pathologies. Otherwise, it doesn't make sense. So can you use the same logic for TMS, for example? Is it not possible? I'm not sure. I'm just asking.
No, currently, we have big trouble with the reimbursement of a strong disease with major depressive episode. And even if there are some proofs and the FDA, the clearance was approved in US for depression, in France, we have a lot of difficulties to obtain the clearance for the RTMS. Because if there is a French approval, that means that automatically there will be a reimbursement by the Social Security. And what we realized that for the authorities say that the cost of the reimbursement is heavy for the nation. Maybe they don't realize that the consequences of depression as well is heavier than the treatment per se. But we have to cope with that currently, and the comorbidity is an additional complexity, which does make sense, because for authorities they have to think not about an additional, but the co-occurrence of two diseases. And as you know, with the major depressive episode, the coexistence of anxiety is very frequent as well. So already the phenomena of a major depressive episode is difficult to define. If you add the co-occurrence of addiction, is an additional complexity. And that's the reason for why there is no reimbursement. And what you explain is that the addictive phenomena is less clear than the phenomena of major depressive episode. And that accentuates, that augments the complexity of the disease.
But on the other hand, you have many more options for treatment of depression. So maybe the insurance companies note that for depression, for major depression, you have more optional treatments, but for some addictions, compared to addictions. So maybe this can give us some optimism that for the case of addiction, still people lose life, and young people lose their, protectability for the country. So it costs a lot of money without potential alternatives of treatment.
Is there any question in the audience? No.
So any other comments? Amin, do you want to ask one question? No? Okay, so we thank the audience for your participation to this neuromodulation session. We hope that we'll have some other session regarding this field, because we believe that it's very important. Thank you very much.
Thank you.